policies and political leadership, a very important part of the story of public health in Sri Lanka. To do this, we have, who would that be? If it is policy, it is Susie. Right? Dr. Susie Pereira is currently attached to the WHO country office after serving as the Deputy Director General of Public Health Services and Director Policy and Planning, a pioneering architect of the primary healthcare cluster model in Sri Lanka. She was a past president of the College of Community Physicians of Sri Lanka. Here is fabulous Susie Madam to speak to us. Ladies and gentlemen, a round of applause.
Thank you, Santusha. I don't know whether I'm going to be glamorous or humorous or whatever. But certainly, I think I was asked to do this topic, and then was asked to also talk about colonial period, and then I was asked by Dr. Sujata to talk about Emani. So I was like really confused and as to how to pitch this. So and to also relate stories, right? Otherwise it can be a little boring, right? So the key point here is about the political leadership, but we really need to understand. So this is my little diagrams. I have a habit of doing this, and once Professor Dulita Fernando, whom I trained under, she and I shared this habit of drawing conceptual, all these diagrams, and it worked well because an academic as she was, and for me being more practice, so these diagrams really helped. And to date, I have a whole array of these kind of diagrams, and that has really helped me as well as how I convey it to others. So that's something that I have built on. So in this whole business of policy, the important part that a lot of people forget is that we think it's, okay, the Ministry of Health driving something. But it's the people, it's the professionals, it's the political opinion, but the lead agency can be the ministry, not always the ministry. So there's an issue and context. This is something that I have kind of come to understand over the years in I've been involved in different policy processes. In all of these, I came to understand the issue and the context is what is changing. And Dr. Sujata wanted me to relate to Emani. So let's see whether I can relate that in a story. So colonial rule, as you know, was all this, and Portuguese didn't really, we don't hear of many contributions to health development during the Portuguese era, but the Dutch, we had the Dutch hospital, and they were mainly looking after their concerns, and they built the facilities to really look after their people. And of course, British era, we had many changes which to date we are benefiting from. This is the drawing of the Dutch hospital, which might interest you, I think. Dr. Margaret Jones, I first met her, actually, I was invited by the University of York on global health histories. They were interested at that time of the work that I was doing on primary healthcare changes when I was at the planning unit, and as director policy. She came and met me. We had a lot of discussions. Subsequently, they invited me to the World Health Assembly to do a joint side event. So that was probably the first side event at the World Health Assembly where Sri Lanka participated. And this is actually just a description of the book, and I didn't really capture the chapter in. I was also, only now I remember actually, the same book I was also, I had a chapter in the same book. But read the second paragraph. So in the British colonial era, towards the latter part of the 1800s, actually when most of our doctors were going to India to be trained, the late 1800s, the Colombo Medical Faculty, medical school was started. And that became a landmark and the oldest faculty, the second oldest in South Asia. And Margaret Jones writes that the people who came from this faculty, the oldest faculty, were the ones actually who helped the system develop at that time in the early 1900s. And of course, previously they were going to the Bengal University in India. So, despite the work going on in the form of health services, if you take what happened in the 1900s, the plantation sector was facing a huge problem, and the whole of Sri Lanka also had effects due to the hookworm infestation. And it was really, if you go back to my little conceptual diagram, it was really the plantation sector who reached out to the European civil society, inviting them to do something, and that was the Rockefeller Foundation. So they came and looked at the hookworm infestation part in the plantation sector, but really couldn't solve that. Right? There were treatments and wide-scale medications done, but that was not really achieved. So although that became a non-achiever, they looked at in health unit-wise, in small areas, they did surveys and they found that the more public health approach in a small area was beneficial to us, and they set up this first health unit, and that gradually expanded. So the civil society at that time, led by the plantations, they asked for this. Of course, the failure was, the plantation sector would have gained, but they didn't want to really address all the social determinants which the Rockefeller Foundation, that group, actually pointed out. So it was not really profitable for them. So it is like today we discuss about commercial determinants and social determinants. It was there those days in a different way, right? So the Rockefeller Foundation came for something else, and we benefited in a different way. I believe this is going to be spoken of later also. So, it was sometime a few decades later, I think S.W.R.D. Bandaranayake, he identified Dr. J.H.L. Comstock, who was an international figure by that time, who originated from Australia, but he was an international figure. And the cry was to look at how the health system should change. So this is now the British colonial, the latter part of it, extending to just after independence, and some help now being extended, right? And if you look at this figure, some of you may have seen this cartoon, and you can see it says meet the twins. So at that time they identified the curative and the preventive twin. The issues around this which could not be solved at that time, and the social determinants that need to be addressed but not quite being addressed through a entirely medical approach, right? So this was something that we need to, sorry. Right, so I'm not going to read all this, but I call these landmarks, and not really, some of them are policies, but they are, of course, landmarks. For example, if you look at 1977 dual practice, what was it brought for? It's a landmark, it's a policy intervention for retention, right? So in today's context, we may need different policies for retention, but that is something that we need to understand. So further landmarks, this is very interesting, health master plan, right? So we did have national health policy documents, but with the JICA support, it was framed as a master plan to help us to identify more concrete policy interventions. But what we forgot was that actually, even in the health master plan, the front-end document is really the major policy direction. So then thereafter, political statements, there are so many political statements. Mahinda Chintana, then of course the economy statement of the Yahapalana government, the NPP political statement recently, they are all very important and very profound statements. And of course the health sector moved on to develop more sector-specific policies. So these are the way the changes happen. And now the health master plan, the current one, which is again going to be reviewed next. So you can see there are so many different, I haven't mentioned all, and if you take, I want to highlight on the nutrition policy. This is an issue of leadership. I mentioned about the leadership is really important. It's for any government, it's high priority. But strong partnerships are needed, and if you take the highest level governance is needed, and this is something that has been swinging back and forth. So I have actually been through so many of these different government stages where nutrition policy has been shifting this way and that way, not the policy governance structure. So there is a strong need to focus on results, which has not happened. Who does what and how much, and its contribution to the overall development. That often gets not understood. These are some of the areas that I have been involved in, and Santosha spoke about this on the primary care reforms. There is a lot, I can talk nearly a day on this because at each and every point, from 2009 onwards, there was a constant, so what I can tell is don't give up, and I think that's what Dr. Mahipala sir, you also said, don't give up. So I never gave up, even though there were times when you have to lie low, but you have to move, you advocate, you somehow to do it, and it actually works because this is about constant advocacy, right? And not only with one person, but so many. I mean, if you take my laptop, there'll be so many folders on different aspects of the primary care involvements from 2009 to 2018 until the policy was actually approved. And this policy still is what is being taken for project mode funding, but we like to see something happening as a health overall health development side, and let's see why that is dwindling. This is another policy area that I was closely involved in, and that's the migration health policy. And I remember, I must mention this, there was a bilateral meeting which we had in Geneva, for which the President Maithripala Sirisena had went, and we thought it was going to be with a group of people. So we had kind of interventions written so that he could read out. But when we went there, we understood that it was just two people talking to the head of IOM there. So what I did was I told the president at that time, I said, sir, it's not that you don't understand, you understand what they're saying. Why don't you speak in Sinhala? I will translate it then and there. And when they reply, anyway, you know what they're saying. And it worked very well, and we had a very good discussion. There was much that we gained, and I'm not going to read what we did. So so this still needs to get into becoming a national program with probably a consultant community physician addressing this as a vulnerable population. So if we have a directorate for estate urban, we can well include migrants. Estate, urban, and migrant. We don't need a separate directorate. We just need a focal point to take this forward, because most of the inbound health assessments have been shifted to the quarantine, which is good. That's what we wanted. Right? So again, I have put a circle here. This leadership, the title for this was Lead on Leadership, the political leadership, but now I think I must have convinced you that it's not only the political leadership. There's so many entities and a lot of leaders need to make this happen. But what often goes missing is what happens to this policy. There are so many policies, but what really happens? Do we keep track? To see whether the context has changed or whether we need a new direction, and that will be highlighting a new issue for another policy cycle. I think we are faced with that today, because this year is the time we are going to look at this policy direction. If we need something, okay, I'm going to stop. Right, so leadership for MNE is governance. Governance role is to take the leadership for MNE. There is no governance if there is no monitoring and evaluation. So it happens at different levels: program performance, health sector performance, but how to bridge it. That's the where people can't understand how to bridge this. So in the health sector performance, actually the National Health Performance Framework, I was working closely on this. And in 2018, we presented when Dr. Tedros came. Okay, I think I missed that. There's one picture I missed, right? So the National Health Performance Framework, I was asked to come on stage and present this as an innovation when Dr. Tedros came in 2017, I think, 2018, right? For the, we had the World Health Day celebration here. But although this document was done, we are seeing a lapse, and because this would have captured a lot of what the whole health sector needs to understand about the performance, right? And so this is I didn't give up on this, right? Because I can remember I trained under Dr. Peter Hornby for my postgraduate work, and he was a strong person who really trained me on performance frameworks and so forth. So for this, actually, years later, I can see I have still kept on that track and contributed to the Ministry of Health with the National Health Performance Framework. And I believe now Palita Karuna Prema, only years later, he is trying to get this onto a dashboard. So anyway, we have to improve, right? And actually the government actually asked for this in different ways. Different governments. I remember Dr. Chandrika Kumaratunga's time, there was a consultant who came for results-based planning. Then Ranil Wickramasinghe's time, he asked, he wanted an external agency to be the monitor for the Ministry of Health. Actually, it was during that time that we thought internally we have to somehow see that this monitoring is strengthened. So that was our response from the planning section to come up with the National Health Performance Framework, right? But governments actually ask every year budget performance, accountability. So these results frameworks have also been asked. So this was a paper that I published very early in my career. This is really the performance framework. I thought I had lost it. Okay, now I'm coming back to this dark picture. Are we still in this situation? The context may be different, but we have similar things to solve. So we have to see that in our effort to change this policy or keep the policy or improve on it, we need maturity to drive this process. Knowledge and appropriate skills and tools, advocacy is a must for policy. Institutional memory, ask for it when you want it. And one person can't do it, it's teamwork. And as Dr. Sujata Samarapon wanted me to mention, the importance of M&E, although we can't go into the details of it, without a strong M&E, which means no governance really. So, thank you.